Hello friends, welcome to my YouTube channel TNC Updates, Toxicology and Critical Care, where we learn about fundamentals of critical care and toxicology and applied principles in these fields. Before we start today's video, a disclaimer to start with. Following videos touch various important topics of critical care medicine and toxicology. The videos are not exhaustive account of the disease conditions discussed. The videos derive their content from various standard textbooks of medicine, critical care, toxicology. But as the guidelines change rapidly as per the new level of evidence, the viewers are strictly advised to follow the discretion and advice of treating specialists. Today we discuss a very common topic and which is seen a lot these days with increasing pollution all around. That is acute exacerbation of COPD and severe asthma. To start with this, we all know what are the differences between COPD and asthma. I won't go into the details, but basically COPD is a disease which is associated with pollution, cigarette smoking, and a disease of the lung parenchyma. Asthma can be due to other causes like allergies, and age group is different. So let us start with a case presentation. A 72-year-old male, known case of COPD, coronary artery disease, and heart failure, admitted to ICU with breathlessness, high-grade fever, cough, with mucopurulent expectoration. On admission, he was diaphoretic, febrile, temperature 102, heart rate 106, BP 110 by 78, respiration rate 30, and saturation on room air 60%. Improved to 80% with oxygen supplementation. ABG done shows pH 7.26, PCO2 88, PO2 45, bicarb 30, lactate 3.5. So initial management, immediately what you will do, you will start with ABC, airway breathing circulation. These patients need to be started on nebulized bronchodilators, oxygen titrated to arterial saturation of at least 88-92%, corticosteroids, antibiotics, and at times on non-invasive ventilation. These are the cornerstones of management of such patients. Fluids, electrolytes need to be monitored on a patient-to-patient basis, as circulatory insufficiency may be present in spite of being edematous, and diuretics in these patients can be harmful. Initial investigations: ABG, chest X-ray, ECG, complete hemogram, renal functions, electrolytes including phosphate, potassium, BNP levels, echocardiography, cardiac troponins. So you will try to rule out the cardiac part. If there is a change in sputum characters with an increased purulence, sample should preferably be sent before starting of antibiotics. In the presence of sepsis or septic shock or associated pneumonia, it is good practice to take blood cultures prior to antibiotics without causing delay in antibiotic administration. In the ER or ICU, there is something called Blue protocol, that is bedside lung ultrasound, which has very good sensitivity and specificity. So what are the risk factors and etiology for COPD exacerbations? Risk factors can be history of prior exacerbations, elderly people, duration of underlying COPD, more the duration, more will be the exacerbations. Mucus hypersecretion, other comorbidities like cardiac, diabetes, hypertension, pulmonary part. So any infection can precipitate an exacerbation. Various viral infections with change of season, especially these days, rhinovirus, respiratory syncytial virus, with chronic lung and heart illnesses, influenza, parainfluenza, adenovirus, coronavirus, human metapneumovirus, bacterial infections, Hib, Haemophilus, Moraxella, Streptococcus pneumoniae, etc. Then non-infectious etiologies can be there. A myocardial ischemia can precipitate an exacerbation. CHF failure can precipitate aspiration and pulmonary embolisms. So classification based on clinical signs and response to treatment and ABG. So basically three categories: no respiratory failure, acute respiratory failure not life threatening, and acute respiratory failure life threatening. In the first, respiration rate is 20 to 30 with no change in mental status or active use of accessory muscles. Hypoxemia is there simply but improves with supplemental oxygen, just 28 to 30% oxygen given, and there is no increase in PaCO2. In second category, tachypnea with use of accessory muscles, and there is mild increase in PaCO2 to 50 to 60. In the third category, there is all previous characters will be there, plus there will be change in mental status, and PaCO2 will cross 60 even. So pathophysiology, what causes acute exacerbation of COPD? COPD patients have resting expiratory flow limitation due to airway inflammation and airway narrowing that leads to insufficient time for expiration, causes air trapping. So end expiratory lung volume fluctuates widely in such patients. During exercise or any situation causing increased demand as the inspired tidal volume increases, EFL, that is resting expiratory flow limitations, they cause an increase in EELV, that is end expiratory lung volumes from baseline, which is called dynamic hyperinflation. So it is all air trapping. So end expiratory lung volumes increase, dynamic hyperinflation, the phenomena occurs, so it causes more of dead space. The patient becomes tachypnic and adopts a rapid shallow breathing pattern which worsens the dynamic hyperinflation. Due to expiratory flow limitation and dynamic hyperinflation, the intrapulmonary pressure remains positive even at the end expiration, which is termed auto PEEP. This acts as an inspiratory load and can be significantly high in acute exacerbation of COPD. So, which are the drug classes, which is a management for these patients? So, we have basically these drugs being used, short-acting beta agonists, which is the first and the most commonly used, salbutamol, levosalbutamol. So, what are the caution in patients with coronary insufficiency, arrhythmias, short-acting beta agonists, or with or without short-acting muscarinic antagonists are the first line of treatment. So here we have ipratropium bromide. So you have to be cautious in glaucoma, urinary retention, and inhaled corticosteroids, budesonide, fluticasone, beclomethasone, then oral steroids, prednisolone. So inhaled corticosteroids associated with oral candidiasis. So systemic steroids have their own adverse effects. Uh, Single agent inhaled corticosteroids are not recommended as monotherapy, although nebulized budesonide alone has been used. Systemic steroid use is associated with improved oxygenation, faster recovery, not recommended for more than 5 to 7 days. Methylxanthines, theophylline, aminophylines, so narrow therapeutic index cause arrhythmias, CNS excitation, not recommended anymore. Antibiotics, if there is presence of worsened dyspnea, increased purulence, increased volume of sputum. So systemic steroids, very important to know when to give, how much to give, and for how much duration to give. So the oral route is recommended in management of acute exacerbations of COPD. IV route is to be used when patients are too sick to take orally. That will be in shock, severe vomiting, peri-arrest situations. So global initiative for chronic obstructive lung disease So this is called the gold guidelines, suggest oral prednisolone 40 milligram once daily for majority of these patients. In cases where IV methylprednisolone is required, trials have shown no benefit for doses more than 240 milligram per day. So we mostly use 120 milligram BD, or even 40 milligram BD is very much effective in many patients. A 5 to 7 day oral steroid course is comparable to 14-day steroid therapy for majority of the patients. Once the patient has improved, glucocorticoid therapy may be abruptly discontinued, as adrenal suppression does not dwell with short course steroid treatment unless the treatment duration is more than 3 weeks. So HPA axis, that is hypothalamic pituitary axis, does not get suppressed with this short course of treatment. So you can stop it abruptly. So this is a classification based on spirometry. Confirm obstruction on spirometry. So FEV1 by FVC is less than 70%. Spirometry assessment of airflow obstruction, these are the 4 grades. And in grade 1, that is a mild one, forced expiratory volume 1 is more than 80%, grade 2 is 50 to 79, grade 3 is 30 to 49, and grade 4 is less than 30%. So this gives you the severity index. Assessing of symptoms and exacerbation, this is symptom based, who will be having. So there will be high risk of exacerbation but less symptoms, high risk of exacerbation and more symptoms. So more than 2 exacerbations or one or more than one hospital admission is high risk of exacerbation. So low risk of exacerbations, low symptoms; low risk of exacerbation, more symptoms, A and B. More than one exacerbation with no hospital admission. So returning to our initial case, the patient was started on oxygen therapy in the ward. He started on oxygen 6 liters per minute via simple mask, and he was maintaining a saturation of 96% now. However, after 1 hour, the dyspnea tachypnea did not settle in spite of improved oxygenation levels, and ABG revealed worsening of carbon dioxide levels. So, most important question in such patients is, how is oxygen therapy titrated? What is the role of high flow nasal oxygenation in acute exacerbation of COPD? And what is the role of non-invasive ventilation? Injudicious and unmonitored administration of oxygen in COPD patients can lead to worsening of hypercapnia, respiratory acidosis. The proposed mechanism is worsening of ventilation perfusion mismatch due to loss of hypoxic pulmonary vasoconstriction. A rightward shift of carbon dioxide dissociation curve because of reduced affinity of oxygenated hemoglobin to carbon dioxide. So this is the Haldane effect which I have been learning from the first year of MBBS, leading to increased PaCO2, increased resorption atelectasis. So more oxygen means there will be more of increased resorption atelectasis due to higher oxygen concentration in the lungs. So there will be reduction in ventilation due to inhibition of hypoxic drive. So all these factors will come into play if you give more oxygen, and it will result in more of carbon dioxide. So Haldane effect and various factors resulting in VP mismatch. So resorption atelectasis, which will result in more of shunt fraction and inhibition of hypoxic drive. So more oxygen means all these. So what it translates into clinical practice. For patients at risk for developing hypercapnic acidosis, those in whom initial ABG shows raised PaCO2 with normal pH and a high bicarbonate level, even lower oxygen saturation, even in the range of 85 to 88, or even you can say up to 90 is acceptable. So don't target 95, 97 in such patients. To start, oxygen therapy with low concentration venturi mask 24 to 28%, or even nasal cannula at just 1 to 2 liters per minute with saturation monitoring is recommended. In acute exacerbations, FiO2 more than 40% is seldom required, and ABG should be repeated after 30 to 60 minutes to check for pH and PCO2. If a patient develops hypercapnic respiratory failure during oxygen therapy, so you will find patients improving the saturation but patient clinically deteriorating. So what is happening is the Haldane effect. The oxygen must be decreased to the lowest FiO2 required to maintain saturation 88 to 92. Such patients should be initiated on NIV, preferably to support ventilation, as when you will sudden withdrawal, if you have once given oxygen, then you will withdraw it, then that withdrawal of supplementary oxygen can cause life-threatening rebound hypoxemia. So that can be more dangerous. So in such patients where you are given initially high oxygen, if you want to decrease the oxygen, ideally shift to NIV, or ideally what should happen is that you should start with low oxygen only. So to sum up in a chart, this chart has been drawn to sum up the things. So there is an acute exacerbation, you do an ABG, you will get patients acute type 2 respiratory failure and chronic type 2 respiratory failure. So chronic type 2 respiratory failure, here the pH will be okay. Here your saturation targets will be very low. In acute type of respiratory failure, pH will come down because of retention of carbon dioxide, and there will be no compensatory bicarb increase. So here the saturation targets will be a bit higher, 92, 94. So you start with the medical management, oxygen therapy, and clinically you keep a tap on sensorium, work of breathing, worsening of hypercapnia with ABG levels monitoring, assess for oxygenation. So there will be 4 ways the patient will behave. In first way, the saturation is maintained. There is no hypercapnia. The patient clinically has a reduced work of breathing and a normal sensorium. So in these patients, you are okay. Your treatment protocol is totally okay. You have to just observe. Second category, saturation decreases. There is no hypercapnia. There is a reduced work of breathing. So saturation goes down, but the patient clinically is better. Reduced work of breathing and a normal sensorium is there. So just saturation is a problem, just increase bit of oxygen with monitoring of saturation and ABG. You can use high flow nasal cannulas. Third situation, saturation maintained. This is the most common situation in ICUs or hospitals. Saturation gets increased or maintained. Hypercapnia worsens, the clinical deterioration occurs. So patient gets deteriorated on application of oxygen, increased work of breathing, and a normal sensorium. So here, once you have given oxygen, you have to give trial of NIV with ABG monitoring and reduce your saturation targets. Intubation shouldn't be delayed if required. Fourth category, the sensorium is gone. Somnolence, peri-arrest, no other alternative than don't delay intubation. What is the role of high flow nasal cannula oxygenation? So high flow nasal cannula oxygenation generates a gas flow of up to 60 liters per minute, which is heated, humidified before being delivered to the patient. Its interface is better tolerated than your NIV BiPAP face mask. This high flow maintains a small amount of PEEP, that is 0.7 centimeter for every 10 liters of flow with mouth closed, and 0.35 centimeters if mouth is open. It reduces the inspiratory time fraction, allows respiratory muscles to be rested, reduces the respiratory rate, thereby decreases alveolar dead space. It produces a washout of nasopharyngeal dead space and reduces the anatomical dead space. NIV role in these acute exacerbations. Despite the unequivocal evidence of regarding the efficacy of NIV, recent audits have found the use of NIV in many centers still remains inappropriate with regards to patient selection. Not surprisingly, the mortality was higher in those who received NIV. So NIV is a boon in the hands of experts, but it can be a bane in the hands of people who don't know how to use it. It's very important rather to know the contraindications for NIV rather than indications. So contraindications are very important. It's very important to know where not to apply. So inability to protect the airway, hemodynamic instability, inability to fix the NIV interface, life-threatening hypoxemias, patient has some GIT symptoms even post abdominal surgeries, copious secretions, retention of secretions, non-availability, no trained medical personnel, don't use NIV. How do I initiate NIV? So, what are the recommendations guidelines? So, NIV, IPAP, EPAP settings are titrated to effect. Start with low settings, say IPAP of 6 to 8, so that the patient tolerates. So, don't start with high inspiratory pressure. So, start with 6 to 8 centimeter of IPAP and EPAP of 2 to 4. The difference between IPAP and EPAP should be always at least 4 centimeter initially and then titrated according to tidal volume. So the difference will increase, tidal volume will increase. But to start with, maintain a difference of 4 centimeter. In conventional ICU ventilators where you don't have NIV separate machines, there PEEP is equal to EPAP and pressure support is selected over PEEP. So pressure support is equal to IPAP minus EPAP. Increase EPAP by 1 to 2 centimeters of water till all inspiratory efforts are sensed by the machine and a breath is triggered. Inability of the machine to sense the patient effort in absence of major leak indicates the presence of auto PEEP, which we will discuss in further slides in these exacerbation patients. IPAP is increased stepwise 1 to 2 centimeter till adequate tidal volume and minute ventilation is achieved with no major leaks. So how do I titrate all this? This is by ABGs. ABGs are required initially at 1 to 2 hours to check for gas exchange. To give an example for NIV, just see this separate case for NIV example. A 58-year-old male chronic smoker with COPD is admitted to ICU with breathing difficulty and desaturation. After continuous nebulization for 15 minutes, NIV at an initial setting of IPAP of 10 and EPAP of 6 is applied. After half an hour, his saturation does not improve at all. What will be the change in settings that you would do? So you will decrease EPAP, you will decrease IPAP, you will increase EPAP to 8, or you will increase the respiratory rate, decrease both EPAP. So you will increase EPAP and IPAP. So EPAP to 8 and IPAP to 14. So criteria, there's some criteria for identifying failed NIV. There can be clinical parameters like life-threatening hypoxemia. Patient clinically shows respiration rate of more than 35 per minute. Patient gets drowsy, mental status. So whenever the patient has these features, just intubate. ABG parameters, if there is worsening of ABG in just 1 hour, lack of improvement in ABG and of pH after 4 hours. So worsening or lack of improvement, both are indications for intubation. Or to start with, even severe acidosis, that is pH less than 7.25 and hypercapnia more than PaCO2, always think of intubation first. So auto PEEP. Auto PEEP results in increased end expiratory lung volume. So, and pushes the diaphragm down, and that diaphragm has to generate enough negative pressure to overcome both the auto PEEP and produce further negative pressure to cause airflow. Thus, a flattened diaphragm instead of dome-shaped diaphragm is at an anatomical disadvantage position for effective contraction and reduces the effective inspiratory strength. With auto PEEP, the intrathoracic pressure increases, leading to reduction in venous return, reduces the left ventricle preload in series and in parallel. That is, increase in right ventricle afterload, which also reduces the left ventricle preload. So right ventricle, left ventricle are sitting in parallel. So when the afterload will increase, right ventricle and left ventricle, the septum in between them will push into the left ventricle chamber. So in parallel also the resistance will increase. So venous return will decrease, that will reduce the preload in series. So both in series and in parallel. All these exaggerated hemodynamic effects of auto PEEP can contribute what it results in hypotension, pulseless electrical activities, and cardiac arrests. So, how do I detect these auto PEEP on ventilators? So, bedside observation of ventilator graphics. So, this is the normal flow time graph. So, in this, the expiratory flow time curve doesn't return to the baseline. So, this is auto PEEP. And if you plot the volume time graph, the expiratory limb again fails to return or touch the baseline. So this is auto PEEP. And if you plot the flow versus lung volume, this is the loop. So in the expiratory limb loop, the again it fails to cross the touch the zero part of the loop. So all these graphs will also be used when we are applying the therapeutic measures to treat these patients. So whenever we are treating these patients, we look at these graphs. So auto PEEP will go down, or this expiratory limbs will start touching the baseline if our therapeutic measures are uh, effective. So how to measure this auto PEEP? That was graphical representation of auto PEEP. So in there will be two sets of patients. One is the spontaneous respiration has been abolished. So these patients are on ventilator. The airway is occluded at the end of exhalation by an expiratory hold maneuver, thereby terminating the flow in expiration and allowing the equilibration, that is equalizing, of alveolar and airway pressures. So the resulting airway pressure represents total PEEP. So at the end of expiration, whatever the pressure is there, so you are just equalizing the alveolar and airway pressures. So that will be total PEEP. So total PEEP minus the external PEEP will be auto PEEP. So other category will be patients who are spontaneously breathing, not on ventilator patients. It requires insertion of esophageal. You need a pressure monitor in the esophagus. So a negative deflection in esophageal pressure from the start of inspiratory effort to the onset of inspiratory flow. So the diaphragm is, I told you, is at an anatomical disadvantaged position. So the start of inspiratory effort starts earlier, but there is no inspiratory flow in the earlier part. So the pressure deviation between these 2 points, that is from the start of inspiratory effort to the onset of flow, it denotes auto PEEP. That is the extra work of breathing which the patients having auto PEEP have to do, and you can measure with the help of balloons in esophagus in spontaneous breathing patients. So what is the role of extrinsic PEEP in such patients? So this is for patients who are on respiratory support. You always think कि मैं PEEP दूं ना दूं. Extrinsic PEEP has no role in patients who are heavily sedated or paralyzed and have no spontaneous efforts. A low level of PEEP, that is 5 centimeter of water, in patients who are triggering the ventilator or are spontaneously breathing, that is on SIMV mode, PSV mode. So those patients in which you want that they should breathe spontaneously, PEEP has to be given 5 centimeter of water, can decrease the inspiratory work of breathing and help improve ventilator triggering by decreasing the pressure gradient needed to overcome auto PEEP. Every time extrinsic PEEP is applied, what you will watch for? Plateau pressure. So plateau pressure gives you an indicator of alveolar pressure, and plateau pressure more than 30 centimeter of water, be careful. More than 30 centimeter, you will cause barotrauma over long time. So whenever you are titrating pressures, watch for two pressures: plateau pressure and peak inspiratory pressure. When only plateau pressures are increased and peak inspiratory pressures are okay, then there is a problem with the PEEP part or the lung alveolar pressures. If only the peak inspiratory pressures are increased and plateau pressures are okay, that is PIP, peak inspiratory pressures are or say 70, 80, crossing 100 even many times, and plateau pressures are okay, then that means there is a problem with the uh, tube part, or there is a problem with the airway part, patient part, or the ventilator part. So that is airway resistance, and plateau pressure indicates compliance problems. So compliance problems and airway resistance problems, these two pressures, plateau pressure and PIP pressures. Always remember the application of external PEEP in such patients has to be done with caution, as it can worsen the lung compliance and exacerbate the dynamic hyperinflation. What ventilator settings do I start with in such patients? Let's start with the from what do I start? So you can take any mode, volume assist or pressure assist. Volume assist with alarm settings for peak pressures, pressure assist with alarm settings for minute volume. Respiratory rate 10 to 12, PEEP initially 0 centimeter of water when the patient is paralyzed and ventilated. Later shifted to spontaneous, we can start with 5 centimeter, and there are no definite guidelines, but there are guidelines regarding watching for pressures. So watch for pressures. That is alveolar pressure, plateau pressure, and peak inspiratory pressure. That is what will help you in titrating. FiO2 titrated to maintain saturation of 90%, 92%. So short inspiratory time and high peak flow of 60 to 90 liters per minute. So target is IE ratio of 1:4 or more while checking that expiration is complete. So this is the target you are going to. So to achieve this target, you will increase the inspiratory time, you will decrease the inspiratory time and increase the inspiratory flow, or you will decrease the respiration rate. All these things you will target in mind of IE ratio of 1:4 or more even. So uh, the absolutely expiratory time is increased, preventing worsening of auto-PEEP. Setting very high flow rates are not advisable as it causes VLIs. So treatment of auto-PEEP also includes optimal medical treatment for airflow limitation. The patient's ventilator requirements can be reduced. So treat pain, treat anxiety, treat fever. So user of larger internal diameter ETT tubes helps to reduce the external airway resistances and better clearance of secretions. In case of acute severe airflow limitation leading to auto-PEEP, the patient will require sedation and paralysis. So where you require a low respiratory rate, a high inspiratory flow rates, so such patients can even require paralysis, sedation in very severe exacerbations. So the main stay of these patients is aerosolized therapy in mechanically ventilated patients. So nebulization. The effectiveness of nebulization depends on generation of aerosol particles, size of particles, ventilator settings, position of nebulizer in the ventilator circuit, dose, formulation of drug, patient factors which are often not modifiable, such as anatomy of airway, lungs, presence of inflammation, mucus plugging in the lungs, permeability of drug across the mucous membrane, clearance of drugs in the lung. For adequate drug delivery, the size of generated aerosols is important. If the size is more than 3 micrometers, majority of it will be trapped in the circuit and upper airway. So what is the target size of these aerosol particles? 1 to 3 microns for aerosol therapy. And the particles less than zero point 0.5 microns remain suspended in the airways and are expelled during expiration. So how do I optimize ventilator settings during aerosol therapy? Mode: prefer a VC mode over PC mode. Tidal volume bit higher. So during nebulizations, the things do change a bit. So VC mode, more of tidal volume, prolonged inspiratory time. You want more drug to be delivered. Prefer a constant inspiratory flow pattern over a decelerating or a ramp pattern. Select lower inspiratory flow rates as tolerated by the patient. So this is just the opposite, but for short time when the nebulization is being done. Avoid both heated humidifiers and heat and moisture exchangers during nebulization. Heated humidity decreases the amount of drug delivered by increasing the size of aerosol particles. H&M, heat and moisture exchangers, must be repositioned at the expiratory end of the circuit to avoid contamination of the environment, and needs to be replaced to avoid obstruction of the filter and expiratory circuit. So nebulization, there are basically these four types what are available in the market. This is the most commonly used, the jet nebulizer. So we have these two coming up, ultrasonic nebulizer machines and vibrating mesh. And this is during discharge of the patients at home, mostly meter dose inhalers, which the patients are themselves trained to use. So in jet nebulization, which is the most common, it uses air or oxygen under high pressure. Ultrasonic nebulizer uses piezoelectric crystals to generate the aerosol. Vibrating mesh, this is very interesting. The drug pumped through vibrating mesh size of droplets depending on diameter of mesh. So meter dose inhalers, there is a propellant through which the drug is delivered through a nozzle. So performance wise, a jet nebulizer, it's highly variable. It depends upon the expertise of the person. It depends on the position of the where it depends upon the various parts. So it is variable. But vibrating mesh, very low variability. Ultrasonic, very low variability, and even meter dose inhaler, it will deliver whatever is to be delivered. So noise and temperature nebulization, the normal nebulization, it's noisy but low temperature. Ultrasonic nebulizer has this disadvantage that heat can lead to denaturation of the drug. So it has gone a bit into disfavor because of the heat part. By vibrating mesh doesn't have this advantage. It has no noise and its ambient temperature which is favorable. MDI, no noise, no heating. Combination treatments is possible. You can mix two drugs, three drugs, whatever you want in jet nebulizer because the variability is there. But in all this meter dose inhalers, it's not possible. In here also you can mix. Treatment time, here is high, here it's low, all three. Contamination is possible in jet nebulization, but here it's low to impossible. So cost factor, this is very high, although vibrating mesh has all the advantages. So in times to come, this part will go down, so it will become more common then. Residual volume, it's high, so more contamination, more residual volume in jet nebulization. Position in circuit proximal to ventilator, 15 to 40 centimeter from the Y piece in the inspiratory limb. Same for vibrating mesh, 15 centimeter from Y piece. Here, if you want to MDI for ventilator patient, you have to use a line spacer. How do I approach the patient if weaning fails? Weaning failure occurs when the patient is unable to pass the weaning test or has to be reintubated within 48 hours of extubation. So approach will have three components. Identify possible factors, therapeutic strategies to address the direct cause, and reattempt weaning again. So what are the possible factors of weaning failure? Most common cause is non-resolution of the primary illness for which the patient required ventilatory support. Malnutrition and hypothyroidism are strong predictors of weaning failure, along with other factors such as myocardial ischemia, delirium, dyselectrolytemia, pneumonia. So if I had to tabulate the various causes, see, weaning failure is very common. So always try to have these factors at the back of your mind. So there can be basically these characters related with the respiratory pathway. This can be CNS related, cardiovascular system related, muscle weakness related, or some endocrine and electrolyte causes. So whenever you are thinking of respiratory causes of weaning failure, you can broadly think of two categories. Either they are related with the resistance, increased resistance, and they're either related with reduced compliance. So this is same I was talking about the two pressures, that is increased resistance will result in increased PIP, peak inspiratory pressures. So it can be tube related, circuit related, or even the patient's air related, that is bronchospasm. Or plateau pressure I was talking earlier, it will reflected in the reduced compliance, so lungs will be affected, It can be because of pneumonia, ARDS, pulmonary edema, atlex. All this will result in reduced compliance. Or even the causes can be out of the lung, that is into the chest wall, affecting the compliance. So effusions, obesity, very obese patients we have here having very difficult to wean. So they will take their time. Intra-abdominal hypertension. So how do I evaluate? So first use your statho. Uh, Check for various equipments, ventilator graphs you have to check. Go for simple X-ray. Go for ultrasound, bedside ultrasound. Go for echo to evaluate the cardiac part. So brain dysfunction, patient can be delirium, depressed. So assess daily awakening. So should be always give sedation-free time intervals when the patient is not sedated. So daily awakening trials are must. Family involvement is must. Cardiovascular system already talked. We can go for ECGs, echo, brain natriuretic peptide, troponin levels, diaphragm and respiratory muscle weakness. Whenever these patients are put on steroids or long-term muscle paralysis, they are bound to have respiratory muscle weakness. So always try to use it for the shortest time whenever possible. These muscle relaxants and high sedation. So phrenic nerve dysfunction or ventilator-induced diaphragmatic dysfunction, like VIDD, or CIPN, critical illness polyneuropathies, myopathies. These are all related with the various causes used uh, because of the disease itself or because of the treatment part. So assess neural drive by measuring occlusion at 100 milliseconds, assess muscle power. So give free periods, mobilize these patients very early. Try to avoid hyperglycemias. Many of these patients are diabetics. So avoid hyperglycemia, have a stricter controls. So electrolyte disturbances, go for your lab reports and try to correct it at the earliest. Weaning induced pulmonary edema. So whenever you have taken out the tube, again you have to patient having pulmonary edema. This is also very common. So during ventilation, what's happening is that positive intrapleural pressure decreases the venous return to the heart, decrease preload of right ventricle, decrease preload of left ventricle, so decreases total intrathoracic blood volume. The positive intrapleural pressure decreases the transmural pressure and the afterload of left ventricle, facilitating the LV ejection. But when you have extubated or you are giving a spontaneous breathing trial, intrathoracic pressure falls, venous return to the heart increases, the transmural pressure increases, and the afterload of left ventricle increases. Thus, increased work of left ventricle together with increased thoracic blood volume can precipitate myocardial ischemia in vulnerable patients. Additionally, spontaneous breathing trial increases oxygen demand by 15% as work of breathing increases due to additional load on respiratory muscles. So COPD is an independent predictor of weaning-induced pulmonary edema. In COPD patients, right ventricular dilatation also due to increased afterload due to hypoxemia, due to the lung part, hypercapnia, dynamic hyperinflation. So all these results in increased adrenergic tone, causes increased left ventricular afterload. All this further worsened by deep inspiratory efforts, which increases the transmural left ventricle and aortic pressure, increases afterload. And overloaded right ventricle encroaches on the left ventricle during diastole. This I already talked. This is called ventricular interdependence. This diastolic dysfunction is an important cause of weaning failure in these patients. So diastolic dysfunction, it is basically a relaxation problem, poor left ventricular relaxation. So management of weaning induced pulmonary edema. So once you have faced with these patients, in patients with increased preload, whenever the preload has increased, use diuretics. Empirical diuretics are not justified, they can be deleterious. In patients with afterload, usually manifest as an increased hypertensive response. During SBT, use NTG, it will decrease both your pre and afterload. These patients should preferably be put back on ventilator, control positive pressure ventilation, maintaining adequate PEEP. Spontaneous breathing trial given once again when the cause is corrected. Patients already at high risk may be extubated and shifted to NIV immediately. So once you are knowing that my patient is already at high risk of weaning induced pulmonary edema, so don't give post extubation simple oxygen mask. Always shift to NIV straight away. Yeah, so, but always remember, when it has already occurred, edema has already occurred, then don't shift to NIV. Then you have to intubate. So always remember, in established cases of post extubation respiratory failure, NIV then has shown to be ineffective and might be associated with increased mortality rates due to delay in intubation. So returning to our case, the patient was extubated to NIV, successfully tolerated the extubation, his nebulized medications converted to inhalers, he was actively involved in chest and limb physiotherapy, vaccination against both influenza virus and pneumococci was advised. Thank you so much for the patient listening. Thank you.